multidisciplinary care. Before we do talk about multidisciplinary care, however, I want to briefly mention ECMO, and we'll start with a vignette where an unvaccinated woman was admitted with worsening COVID-19 in the late second trimester of pregnancy. She had been eligible for vaccination for several months, but there was no documented discussion about SARS-CoV-2 vaccination in her records. She underwent a category 3 cesarean section birth in the late evening, and she appeared to be improving initially, self-ventilating on high-flow nasal oxygen, but had a respiratory rate of 40 to 50 with worsening oxygen saturations. So non-invasive ventilation was commenced. She developed pneumomediastinum and a pneumothorax. On day 5 postnatally, an ECMO referral was declined because the ECMO team felt that maximal ventilation had not been achieved. So she was intubated and ventilated. When she deteriorated further and re-referred for ECMO, she was declined again because she had been ventilated for 8 days by that point. Her condition continued to deteriorate, and she died of COVID-19 pneumonitis 3 weeks after giving birth. So 3 points to highlight here. The most important point is that we found, not in this case obviously, but that women still are not being referred to ECMO in the first place, or that they're being referred late. We also found that there was varied advice given out by ECMO services for women with respiratory failure, depending on which service you were referring into. And that outcomes may have further been influenced by the fact that there was very variable medical management of COVID-19 in pregnancy, in particular in relation to steroids, tocilizumab, and vaccination. So some consensus advice on the referral and admission of patients with severe respiratory failure to the NHS ECMO service was developed quite early on in the pandemic, and I would refer you to this article. And just also highlight that from the ELSO registry data, COVID-19, women with COVID-19 are both more likely to need ECMO, but they're also more likely to survive as well. And if we zoom back to the previous big pandemic, the H1N1 influenza pandemic, there was a 75% maternal survival rate and a 70% live birth rate. And so we're asking for updated guidance on ECMO for severe acute respiratory failure in adults to include specific information on referral and admission of pregnant and recently pregnant women with respiratory failure to ECMO services. And just to focus on some previous recommendations made, ensure care for pregnant and postpartum women with COVID-19 follows the Royal College of Obstetricians and Gynecologists and RCM guidance to ensure that protocols for assessment and monitoring of pregnant women with COVID-19 in the community take account of known risk factors for severe disease in pregnancy, and also that referrals to the NHS ECMO service should be made for pregnant women or women post-pregnancy using the same criteria as for other adult patients, i.e. if worsening severe respiratory failure despite appropriate conventional ventilatory support, or for women in whom lung protective ventilation cannot be achieved because of the severity of hypoxemia or hypercapnia, or a significant air leak. So we're going to move on to focus on multidisciplinary care now, and this is my second and last vignette. A young primiparous woman had a cesarean section for failure to progress after induction of labour. She showed evidence of infection during labour, including mild pyrexia and tachycardia treated with IV paracetamol. Post-cesarean, she developed puerperal sepsis, requiring ICU care for organ support. After initial improvement, she was transferred to a different hospital for ongoing management of a persistent renal injury. She subsequently deteriorated further, and despite escalating efforts to achieve source control, culminating in a hysterectomy, she eventually died from multi-organ failure. So early recognition and senior multidisciplinary review are essential in the survival chain for these women. And to go back last year, MBRRACE highlighted that maternity-specific EWS should be used in whatever location you are if you're dealing with a pregnant patient. However, moving on to some key features that makes for successful multidisciplinary review, we know that it should be timely, so it should be early. We know that senior involvement is particularly important, and MBRRACE has highlighted this in the past. Something that is also important, however, is that it is collaborative, that there's communication between multidisciplinary teams. And for that to best happen, it should be then concurrent, i.e. occurring at the same time. And so if I can highlight an instance from another case, which was an anaesthetist was asked to insert an epidural for labor analgesia, but declined to do so because they were worried about sepsis in the patient. This transpired to be true, and the woman eventually went on to deteriorate significantly. However, it would have probably been a good time for everybody to get together to have a conflab and discuss next steps at the same time. So when there's a key event, it's very, very useful to bring everybody together, all of the senior multidisciplinary team together to discuss how we're going to proceed and to understand each other's concerns. It's really important that good critical care can be delivered on labour suites. And since 2018, when the document Care of the Critically Ill Woman in Childbirth Enhanced Maternal Care was published, there's been variable progress with development of enhanced maternity care in hospital settings. The Intensive Care Society has very recently, in the last couple of weeks, released this document, and I would just signpost you to it because it gives some very useful advice on the development and implementation of enhanced maternity care units. It's really important that critical care services can be aligned around these women, but it's equally important that maternity services are aligned around women with critical illness. And so, thinking more broadly about patient pathways and proximity, there can be no argument that maternity and critical care co-location are extremely valuable. And there are many instances where patients had to be transferred to get specialist services or to get critical care, sometimes to another hospital, sometimes to another centre. Maternity services must be available to critical care. It's unusual, but there are very predictable emergencies that can occur if a pregnant patient is cared for on the ICU, and these include birth, postpartum hemorrhage, and cardiac arrest, to name but a few. There was an instance in another case where the maternity unit and the critical care unit were located in completely separate hospitals, and a woman on the ICU had a postpartum hemorrhage. To be fair to the centre, they had arranged for a midwife to be stationed outpost on that unit, and so there was some readiness available. But nevertheless, there was quite a high degree of stress involved in dealing with that situation without the immediate expert advice of obstetricians, etc., who had to attend later. So this case vignette highlighted that an instance of transfer. And as I mentioned, there are many instances where transfers for specialist input had to occur, and it can be beneficial and sometimes is vital, but it does add challenges. And so just a final point on this idea of pathways and proximity. I note that up and down the country, there are plans to build various new maternity units, and those involved in the project design must consider the impact on the deteriorating maternity patient in terms of where they are going to build these units, but also, how we're going to get services around the deteriorating maternity patient, including access to transfusion, access to critical care, access to other specialist services in an emergency. It was unusual for transfers to be well documented. Yet it is a significant time of exposure and risk for women, especially women who are critically unwell. And it goes without saying that there should be detailed communication between all teams when there's a transfer of care, so that the transfer of care can be as seamless as possible, and there's no lag or gap. And that's an absolutely vital patient safety point. So, to sum up and some recommendations, these are pre-existing recommendations, but we'll go through them one by one. Suspicion of significant sepsis should trigger an urgent referral into secondary care. There should be an urgent referral to the critical care team in severe or rapidly deteriorating sepsis, and the involvement of a consultant obstetrician. The expert advice of a consultant microbiologist or infectious disease physician should be sought urgently when sepsis is suspected. The RCOG Green Top Guideline 64A comments. Sorry, that was in relation to the RCOG Green Top Guideline 64A, and then another point from the RCOG Green Top Guideline 64B. Women with sepsis in the puerperium are best managed in a hospital where diagnostic services are easy to access and intensive care facilities are readily available. And then finally, there should be adequate provision of appropriate critical care support for the management of pregnant women who become unwell. All consultant-led delivery suites must have access to level 2 critical care facilities that are appropriately equipped and staffed by teams of senior obstetricians, anaesthetists, and midwives skilled in looking after seriously ill women, especially those with sepsis. And then, if I can underline, plans should be in place for provision of critical care on delivery units, if this is the most appropriate setting for a woman with sepsis to receive care. And then also, conversely, we must remember as well that there must be proper plans in place for women and the delivery of maternity services to critical care when women are admitted there as well. And with that, I'm going to finish, and I'd just like to thank you very, very much for your attention.